So, welcome to another episode of our channel at Merus Gastroenterology and Gut Health. Today, I have a very special guest, Dr. Karen Kaufman with the Kaufman Allergy, close to Washington, D.C. And they have a very busy practice there and a household name near Washington, D.C. So, that's amazing. Welcome, Dr. Kaufman.
Thank you for having me.
Absolutely. Could you please tell us more about your practice, how you got there, and what you guys do?
Yes,
That'd be great.
absolutely. Thank you. So my name is Karen Kaufman, and I am the founder and CEO of Kaufman Allergy, Asthma, and Immunology, where we care for children and adults with allergies and recurrent infections and help them to regain the quality of life that they deserve, utilizing the least amount of medications, but really focusing on patient-centered care. And it's just been a real joy to serve the community here. The practice opened just over 2 years ago in the midst of the pandemic. So it's been busy and crazy since the beginning, but we are so grateful to serve now over 3,000 patients in the greater Washington, D.C. area. And it's just an absolute joy. So thank you for having me here. I'm really excited to chat with you about a topic that I spend a lot of time talking with patients about here in my clinic.
Absolutely. Yeah, welcome. I am thrilled to have you. And yeah, so today our topic is about mast cell disorders, and we'll try to unpack and understand what does that mean? What are the symptoms? What can we do? Because me in my gastroenterology practice, I'm seeing more of that, which is new, I should say, even in fellowship at Penn State, or we haven't really come across a whole lot other than really reading in the books in the gastroenterology field. But I understand there's some overlap in these mast cell disorders with GI symptoms, and that's where we get to see that spectrum of the patients. And I wonder if it's got something to do with COVID as well, exposure to COVID. But let me start off by asking you what is mast cell disorders? What are mast cells? Where do you find them? How would you define them for our patients? Make it easy for them.
Yeah. So mast cells are immune cells, and they're immune cells that are found particularly in places of our body where we have sort of an interface between ourself and the environment around us. So we find mast cells in the respiratory tract, in the gastrointestinal tract, of course, around blood vessels, and in the connective tissue as well. And so these mast cells are part of our immune defense against some things that may be dangerous to our bodies. And so inside of the mast cell, there are a whole bunch of different types of what we call immune mediators, which all contribute to symptoms when they come out of the cell. And as they affect different areas of the body where they are located, we start to see more localized symptoms. The reason why mast cells generally, fall under, our field, of course, well, they are immune cells, but as an allergist immunologist, one of the most common ways that we see mast cells are in the setting of allergic responses. And when we have allergy, and that's really no matter whether it's to environmental allergens or stinging insect allergens or food allergens, as our immune system responds, the symptoms that we experience as part of an acute allergic response all happen because of some of the mediators that come out of these cells and how they interact with our body. So they're really fascinating cells. There's so much to learn about them, and we're talking about them now more and more.
Yeah, that's amazing. So they're everywhere, pretty much all over the body. And then when they're interacting with some allergens, now they release some chemicals that would cause symptoms.
Yeah.
What sort of symptoms do you guys see? I know we see some spectrum of like maybe bloating, diarrhea, nausea.
Absolutely.
What else could happen in these patients?
Sure. So in the setting of allergy, we talk about mast cell degranulation in the setting of what we call anaphylaxis, which is the name of a severe allergic reaction that responds to affect multiple body systems. So in addition to gastrointestinal symptoms that we may see, including abdominal pain and cramping and bloating and vomiting and diarrhea. Also, we see skin symptoms like flushing or hives or swelling. We may see respiratory symptoms that may look and seem like asthma type symptoms like chest tightness, coughing, bronchospasm, wheezing. And it could also include cardiovascular symptoms, including the drop in blood pressure. So, when we see these acute responses, for example, in the setting, let's say, of a food allergic response, right? You have an accidental ingestion of a food allergen, and then these symptoms may manifest usually in the setting of immediate hypersensitivity. So seconds to minutes to maybe an hour following that ingestion. And we see some constellation of these, multiple body system reactions. And in the GI tract, especially, there are so many mast cells in the GI tract, because when you think about that interface between our body and the environment, that's one of the largest places that we have that interface. And so there are so many mast cells that are present. And so as they degranulate, gastrointestinal symptoms are actually pretty common.
Yeah, that's amazing. So are all anaphylactic reactions, whether it's with a bee sting or certain nut allergies, mediated by mast cells? Is that?
Yeah, so mast cells are involved absolutely in anaphylaxis across the board. So in the setting of an acute responsive anaphylaxis, mediators that are normally found within the cell then come out of the cell, and we'll find them in the circulation, which usually we don't find some of those mediators in the circulation for very long. So one of the hallmark and it will be elevated from the patient's baseline in the setting of acute degranulation. So that is one thing that we can evaluate and follow, although usually I would say it's almost never that we find that patients have a laboratory value of, checked in the setting of an acute reaction. It almost never happens, but yeah, so we'll see some of those mediators in the setting of a response.
That's amazing. Yeah. But so we just had touched upon, we are seeing more and more of these now. Is there a reason? I mean, if it is mast cell, an allergen that's around us, maybe food or so on, how or why is the incidence changing, or why are we seeing more of it now? What do you think?
Yeah, so what we are seeing more of now, and I would say the amount of allergy that I see has been consistent through the years. I mean, that's not really that much different, but mast cells now have become a more recognized problem, because some people experience a functional disorder of their mast cells, where they may be degranulating or releasing these immune mediators without an obvious trigger. So in the absence of the presence of an allergen or a known immune response. And so we call this, idiopathic mast cell activation syndrome, or mast cell activation, which, it's essentially the same problem where patients are experiencing these symptoms of anaphylaxis that are due to the release of these immune mediators, but it may not be triggered by the presence of an allergic response.
Interesting.
So
that would be scary. Yeah.
Yeah, so we have been seeing this so much more. I would say in the last maybe 10 to 15 years, this is more of a newly described entity, where prior to that, we used to talk about idiopathic anaphylaxis, which was, the anaphylaxis, which the workup just didn't really lead to a whole lot of answers. And we kind of said, well, this is what to do in the setting of an emergency, but I don't know what to tell the patients to avoid. And that was kind of that. So what we find now may be more in line with this idiopathic mast cell activation is non-IgE or non-allergic mediated mast cell degranulation. Yeah, so really fascinating.
Are there any triggers for this to happen, like trauma or prior infection?
Yeah, a lot of triggers. So trauma is definitely one. Acute stressors, acute infection, lots of things. Big shifts in things happening with the body, like surgery, I've seen as a major trigger. And as illness has been a trigger, we've seen in a lot of folks some overlap of symptoms of what we see with idiopathic mast cell degranulation overlapping with long COVID. So that's, I think, maybe, maybe why we've been seeing it even more now, or maybe it's more in our, in our front of our minds as we're seeing more and more of it.
Right, that's interesting. So when you see them in the setting of COVID, these patients have had COVID in the past, have recovered, and now they have these intermittent symptoms of mast cell degranulation with what symptoms do you see? Do you see a specific spectrum of the symptoms, or do you see pretty much everything?
Yeah, I do see a lot of fairly broad spectrum, but I would say
Mhm.
gastrointestinal symptoms are probably present in at least maybe
Mhm.
80%, 60 to 80% of people with symptoms
Interesting.
relating to mast cell degranulation. It's often, bloating, cramping,
Mhm.
nausea. A lot of the symptoms actually interestingly overlap a lot with what we think of as IBS.
Mhm.
And interestingly, in patients who have IBS, they'll, in looking in the literature, sometimes there's an increase in the presence of mast cells in the gut in those individuals. So, we wonder how much that the degranulation of mast cells contributes even to things like IBS.
That's interesting. So that makes me wonder how many of my patients may have this going on while I'm trying to do other things like colonoscopy or put them on fiber. Is there like, do I have any labs I could follow or any way to test them to differentiate between what I thought of as routine IBS? You rule out everything. It's a diagnosis of exclusion, right? Everything,
Yes,
nothing is going on. Well, you have IBS, but and then we are limited in options as to how do we treat these patients. And if
right.
there is a way, if this is one of the things that might be going on, that's, opens up another door to manage these patients. Is there
Yeah,
something we can look here?
it's an interesting thought. And the thing is that in diagnosing, idiopathic mast cell activation syndrome, it's idiopathic. So just like IBS, it's kind of a
Mhm,
diagnosis of exclusion. So you have
mhm,
to rule out allergy, and you have to rule out other immune problems that are contributing to, mast cell degranulation. Additionally, you have to rule out clonal mast cell disorders, like what we think of as systemic mastocytosis, which is a problem where, there is a mutation in the growth factor of the precursor cells in the bone marrow that are
mhm,
leading to an overpopulation of mast cells, and as they degranulate, they can cause similar symptoms. So distinguishing the difference between mast cell degranulation for any other reason is
mhm,
important in the diagnosis.
mhm,
And otherwise, really, these individuals need to have clinical symptoms that are
mhm,
suggestive, which really are the symptoms that we see within the spectrum of anaphylaxis.
mhm,
Um, and they do need to get better with treatment. So we'll talk a little bit about different options for management.
sure.
But from a diagnostic standpoint, there's not a lot of testing to
Mhm,
do. These individuals will have a rise in their serum tryptase level, as I had mentioned, in the setting of mast cell degranulation. But what's interesting is that their baseline may be normal, and the
mhm,
elevation that we see may not be elevated above a reference range of the laboratory, but it will be elevated from their baseline, usually by about 20% plus two. And
mhm,
so, sometimes that's a misconception when patients are being evaluated by doctors and they'll say, well, your tryptase is normal, so you can't have this problem.
mhm,
It doesn't really necessarily mean that they can't.
mhm,
You can look for a couple of other mediators in the urine. There are some 24-hour urine collections that you can do looking at prostaglandins and histamine, but looking for some of this stuff in serum is just not that helpful,
mhm,
unfortunately. And
mhm.
there's not necessarily a test that you would do that you would say, well, this is you have a positive this
It couldn't
test,
be that
so you
easy,
have
right?
it. It's not that
It's,
easy.
it's not that easy.
Exactly.
Yeah,
But
so
but many of these individuals, particularly with GI symptoms, respond very well to medicines that target
mhm,
mast cells in the GI tract. And so,
mhm,
we use a lot of histamine blockers, H2
mhm,
antihistamines like famotidine as an example.
mhm,
And they have great, improvement in symptom relief from reducing the burden of histamine in the gut.
mhm.
We use some mast cell stabilization medications like Chemolin,
Hormonal, mhm,
and patients do pretty well with the
mhm.
reduction of bloating and nausea and cramping, things like that.
Awesome, awesome. Yeah, so those are the main treatment modalities then for mast cell is famotidine and cromolyn.
For the gut, yeah, for the gut. So,
Mm-hmm.
these folks will also be on H1 antihistamines, and we usually will rely more upon your second generation drugs like cetirizine
Mm-hmm.
or loratadine or fexofenadine.
Mm-hmm.
And we'll use them sometimes even in higher doses than you would typically use for something like environmental allergies,
Mm-hmm.
as we try to block, other histamine receptors in the skin in particular, where we don't have medications to directly target. And I would say the H1 antihistamines tend to do a better job for skin symptoms, especially itching, flushing, hives, things like that.
Mm-hmm.
Um, Sometimes we'll use leukotriene antagonists,
Mm-hmm.
and sometimes they will be helpful in reducing abdominal pain. Um,
Mm-hmm.
Sometimes not.
Yeah,
That's
yeah,
mixed,
yeah,
mixed
yeah.
responses.
No, that's
Yeah.
useful. That's really useful. I mean, to at least a famotidine, anyway, we use it, right, for in
Mhm.
GI. And if I could use it in these patients, although they may not have acid reflux, this will give me an idea if it's helping or not. And cromolyn, is this the only clinical indication for cromolyn? Is it used in any other disorders? Anything to keep in mind as in terms of like caution or side effects when we use that?
Mhm. I kind of like to think about cromolyn as one of those medicines where it works where you put it. So,
Mm-hmm.
I think, we sometimes will use cromolyn in the form of a nasal spray, but
Mm-hmm.
that's not going to fix GI symptoms.
Right.
Cromolyn
Mm-hmm.
in the nose is going to work on the nose. So cromolyn in the gut tends to work on the gut.
I see.
I usually will start patients on a lower dose, a typical dose, but a lower dose,
Mm-hmm.
and then, titrate up depending on what their need is. But it's pretty well tolerated. I would definitely say that when I would say maybe it's a little bit trickier is more when patients have a big predominance of constipation versus a diarrhea predominance.
Mm-hmm.
That makes it a little bit trickier because I
It
think
tends to
sometimes,
constipate. I see.
yeah, it can
Mm-hmm. Mm-hmm.
constipate a little bit. So it's
Mm-hmm.
something that I kind of keep in mind as I start patients on cromolyn. But I usually will take a stepwise approach, starting with, optimizing dosing of H1 and H2 antihistamines first, and
Mm-hmm.
then I will add from there depending upon the need. But it's interesting because every patient's different, and
Mm-hmm.
ultimately the goal is to get their symptoms under the best control possible using the least amount of medicines.
Right. Right.
So, it's really tricky, and sometimes it's hard to sort out that initial difference, right? Could this be
Yeah.
a mast cell
Mm-hmm.
dysfunction, or is there something else that's driving this?
Mm-hmm.
Even for folks with bad environmental allergies, we
Right.
have to fix the allergies first before you can say, well, your mast
Mm-hmm.
cells are
Mm-hmm.
dysfunctional, you
Now,
know.
is there that makes me wonder if there is for mast cell disorders with predominantly gut symptoms, diarrhea, nausea, vomiting, or well, vomiting, I guess more is more acute. Would there be food allergens that we could test for? And is that part of, does that make sense in this setting?
Yeah, it's such a good question. So, the way that I like to think about food problems and food allergy
Mm-hmm.
is really depending upon what's driving it. So, in the setting of food allergy, it's mediated by the presence of IgE antibodies. And so, what's
Mm-hmm.
interesting is that in these individuals who have mast cells that are frequently degranulating, sometimes doing allergen skin testing can
Mm-hmm.
even be misleading because sometimes we'll even see false positives on skin tests. So I tend to measure IgE antibodies more often than I'll do skin testing sometimes because
Mm-hmm. I see.
you either make antibodies or you don't.
Mm-hmm.
So food allergy is going to manifest by way of immediate hypersensitivity. So we're going to really see more of that picture of anaphylaxis
Mm-hmm.
with primary food allergy.
Mm-hmm.
But interestingly, there are a lot of foods that are naturally high in histamine. And so for some of these individuals, when they kind of have too much histamine, like above whatever the threshold is that they tolerate,
Mm-hmm.
sometimes they tend to have worsening symptoms, particularly GI symptoms of, bloating, cramping,
Interesting.
nausea, and
Mm-hmm.
sometimes even skin symptoms like flushing.
Mm-hmm.
And so we do tend to look at the diet to say, and the way I like to do it is, when we're talking about more of a picture of food intolerance, which is what histamine intolerance is versus food allergy, the way
Mm-hmm.
to diagnose it is with a food and symptom diary. So I kind of
Mm-hmm.
teach the
I see.
patients how to track in the way that makes the most sense to me, which is really head-to-head tracking of ingestions and symptoms and looking at severity scores and trying to like kind of look at the big picture to say, is there, are we having too much histamine in the course of a meal or too much histamine in the course of a day that are contributing to worsening symptoms? And so we kind of look at it that way. So sometimes I see patients who have seen, other providers that say, well, pull all these foods that are high in histamine out of your diet, which is actually truly impossible to eat a no histamine diet. So, really it's a volume issue. So we try to say, look, eat the best way that you can, but either reduce volume of an individual food that's high in histamine, or maybe reduce the combinations of foods so that the volume of histamine ingested over the course of a meal might be less, or over the course of a day might be less. And it tends to help for some people. So I always like to look at it. To me, that's an easy thing of saying, look, let's track, let's see if it makes a difference. If it doesn't, go back to eating how you normally eat. And if, eating a low histamine diet helps, then that's an easy modification that doesn't necessarily involve taking more meds.
And so when you track at these food or see the food journals, what's the duration where it becomes no longer is impacting the symptoms? Somebody had it day before yesterday or versus yesterday versus this morning and had symptoms today. Are we still considering what he had 48 hours ago, or how long is the association between?
It's a good question. I don't necessarily know that I have a strict definition of the answer, but the way that I tend to see it, it depends on when the symptoms present, but I would say within 24 hours is pretty relevant. 48 hours is far. Yeah.
And those histamine foods, what are some commonly known histamine rich foods?
Many of them are foods that go through the fermentation process. So a lot of things that people will commonly.
Here we are saying probiotics, eat fermented foods.
Right. It's like the opposite of a live on MAP diet, which a lot of our colleagues in GI put a lot of patients on who have like SIBO and other GI problems. It's really tricky. So, wine and beer are at the top of the list. Those are things that very commonly cause symptoms. But, in addition, I would say some of the foods like aged cheeses and cured meats and certain fruits and vegetables like tomato and spinach and kale and mushrooms and avocado and things like that. There's a fairly hefty list. So again, the goal is not to say, let's pull all that stuff out of the diet. It's just like, let's not have 2 slices of pepperoni pizza and a spinach salad with mushrooms and tomato and avocado and a vinaigrette dressing and 2 glasses of red wine. It's probably not the best meal.
Right.
The example I use a lot.
Yeah. Awesome. This is very useful to me in my practice too. So I'll look at these patients in a different light and probably consider, although it's not easy to separate the true IBSs from an underlying mast cell, probably.
Right.
And so if they had an infection of COVID, so to say, or could it be any viral infection? Would that make it more? I guess it's just one other factor that makes it more likely this may be mast cell disorder.
I don't know that I can even really truly say that, but I will say that post-COVID infection, I just see so much more of it. And maybe it's because patients are more aware of it too. I don't know. I don't know if that's really true, but I see a fairly high volume of patients who sometimes are not sure if they have mast cell disorders, and they come to have an evaluation and see if we can start sorting it out.
Awesome. That's super helpful. This discussion for me personally, yes. I had one last question. I know you have to run. There was some articles, of course, this is like a thing, gut microbiome and mast cells, and then could we manipulate the gut microbiome and perhaps impact or decrease? Any thoughts, or it's just so?
The mast cells are really triggered by external stressors. And so, when we see them kind of getting engaged and starting to release mediators, we see problems of, gut permeability. And it's really, I think the microbiome does have an effect because that's part of the protection of, our external environment from our bodies. And so
Yeah.
when that's gone, that barrier function gets disrupted. I do think that the mast cells have maybe more of a role, but they're in there.
Yeah.
I know most people, I think, don't necessarily look at biopsies
Mm-hmm.
and stain them for
Mm-hmm.
mast cells, but we
Mm-hmm.
know that they're in there. And certainly I think doing special stains, some people will ask me like, oh, can you tell my doctor to do special stains? I don't know that it helps me to determine,
Mm-hmm.
how much is too much, or I don't really know
Mm-hmm.
that I know the answer to that, but
Right, right. Yeah.
yeah.
Because in colonoscopy for diarrhea and such, we would
Hmm.
get biopsies. So I could ask if it was a definitive way of finding out. But like you said, if it's not that clear, then I think it only confuses the picture.
It does. Yeah, I
By
agree.
asking, yeah, yeah. And lastly, I think somewhere along we touched on stress probably also as a trigger for mast cells. So there could be a role for like mind-body therapies like meditation and yoga or stress coping mechanisms, or I
I
guess they
think
help
I
everything.
think that that's yeah, I think that that's definitely worth exploring. I know there's just so
Yeah,
many physical benefits of meditation.
yeah,
Maybe
yeah.
chilling out the gut is one of them.
Great, awesome. Yeah. Thank you so much. Any other pearls you would like to leave as we close this discussion?
No, I
Um,
think we did such a nice job. It's a really nice overview. I will say, sometimes these patients are people that have a lot of medical complexities, and sometimes are individuals who maybe are discounted or, told that
yeah,
they're too complex. And so,
yes.
I think just taking the time to,
Mm-hmm.
listen to their symptom history and to really be empathetic to the needs of patients really helps them to understand what's going on better as we can, be teachers as physicians, and people do get a lot better.
Mm-hmm.
So
Yeah,
yeah,
I think
it's good.
that's so important what you said because it's some part of it is that we may not be as comfortable or educated in that disorder. Then now we are overwhelmed by when the patients are complex. But what you said to take the time
Yeah,
and to listen and yeah, figure it out that really helps. Yeah.
it's great.
Awesome. Yeah. Thank you so much for being here and
Thank you for
teaching
having me.
me. In addition to the audience, I'll take some of this back to my practice. I really appreciate that.
Yes,
Yeah,
thank you for having me. This was such a great chat.
absolutely. Thank you again. All right. Take care. Bye bye.